I suppose now we are online.
Yes, sir. Go ahead, sir.
Yeah. Good afternoon, friends. And much awaited Tuesday afternoon has come again to learn about various principles on which we build up our orthopedic career. We are fortunate we have with us Dr. Anand Thakur, who would be speaking to us on intertrochanteric fractures and transcervical fracture as well. And we have as expert panel Dr. Ajit Phadke from Yatmal. We'll be having his expert opinions. Dr. Alok Umbre would be coordinating with me. Whatever questions are there, Alok's number was given onto the information portal, and you can put your questions to Alok. And what today we have a topic is a very interesting topic. Many times we put a transcervical fracture on fracture table, and there are difficulties. The difficulties could be in reduction. Difficulties could be many times I was struggling to just gain the guide wire in right position, and in a dense cortical bone it used to flip up. So this most of you also would have experienced. So let us listen from the master to get the guide wire right, to get the best TAD and measurement, to get the guide wire where we want it, and to learn about the newer techniques as well. So most welcome, Dr. Thakur sir. We are all eager to listen to you. And as I got the feedback from most of the PG students and young practitioners as well as the seasoned practitioners, they all look forward to your lectures. So sir, welcome for your talk.
Thank you. Thank you very much. Hip fracture is such a bread and butter for you and me that each one has treated many hip fractures in the career, or even at the beginning of the career. So much so, we are so accustomed to it that everybody now thinks he is the master. Of course, he is the master because he has been very successfully handling fractures for a very long time. However, sometimes there are issues, and those certain issues one should talk now and again. So that is my endeavor this afternoon to discuss a few topics which may interest you or which may make you thinking that what's on. Let's see. Okay, we all use hip fracture table. Now, whenever the the perineal post is the real trouble. If it is less than 10 centimeters in diameter, then it causes a severe amount of pressure, and there could be pressure necrosis, there could be damage to the nerves, there could be damage to the pudendal nerve, or even to the urethra, and so on and so forth. Not only that, the small one, if one abducts the good leg, then the pressure on the area doubles up. So whenever you use a perineal post, it should never be less than 10 centimeters in circumference. If the one given by the manufacturer is smaller, you should pad it up and make it at least 10 to 15 centimeters in circumference. And the contralateral leg should not be abducted, because doing so, the pressure increases here. When you reduce it for more than 10 centimeters, you can see the amount of pressure dramatically reduces. So always make sure that the circumference of this perineal post is more than 10 centimeters. Now coming to an intertrochanteric fracture, where should you place the post? On the contralateral side, right in the center, or on the affected side? Well, let's see. If you put it on the affected side, the circumference, the 10 centimeters, which is minimum, will press on the soft tissue, and the soft tissue will press on the fracture. And more traction you give, the vector will go in this direction and your fracture will open up. It will not reduce. Whatever you have reduced, more you give traction and medially it will open up. So putting the perineal post on the affected side is detrimental for maintenance of reduction. The safe place is to put it against the contralateral side. Now nothing is pressing or no, the soft tissue on this leg is free of any encumbrance. There is no push sideways. And since it is 10 centimeters and longer, there is no bad effect on the soft tissues here. Now when you give traction in this direction, the vector falls right across obliquely and that brings back the fracture together. So next time we do an intertrochanteric fracture, make sure perineal post is larger than 10 centimeters in circumference and is opposite the opposite side, on the good side, on the not on the contralateral side. Also make sure that the limb is not widely abducted, because moment you abduct, it's going to increase the pressure as I showed here. So best position is leg, the perineal post on the contralateral side, leg reasonably straight, and then you can reduce and maintain your traction. This is the best position that we should go for. Now, when it comes to taking X-rays in transcervical or intertrochanteric fracture, we take a lateral view. Lateral view, anybody say lateral view of the hip? We say yes, fine, it is true. What is about true and Lowenstein? What is this new stuff? What we normally take is we put the patient on this and keep the beam horizontal and take an X-ray. We get something like this. And this is called Lowenstein view, Lowenstein. In fact, this is the true lateral view of the shaft of the femur. The neck of the femur is anteverted by 10 to 15 degrees. So this is oblique lateral of the neck of the femur, but true lateral of the shaft of the femur. This becomes important when you want to get your pin right in the center, because what you are seeing in this is not actually what is happening. You are getting an oblique picture and you're thinking that it is straight. And that's why the mistakes occur. Just to convince you that this is not the true, you can see the greater trochanter side is somewhere here. So shaft and rotator trochanter one side, neck is anteverted. So this is lateral view of the shaft of the femur, oblique lateral of the neck of the femur, popularly called as Lowenstein view. Now then what is true lateral? True lateral is something like this, where the head and the neck and the rotator trochanter all in one line. You see them as one single block. And this is the true lateral. In this, everything that you see is in one plane. How do we get this one? It is very simple. We tilt the tube 15 to 20 degrees in this fashion. Then what you use, that takes care of the anteversion of the neck. And now you will have a picture which is true lateral of the neck of the femur, which is what is required in the method that I'm going to discuss presently. Just for comparison, you have this the Lowenstein lateral with the greater trochanter flying away. And this is the true lateral, which is by 20 degrees tilt. It is not exactly 20, 15 to 20. You have to check and balance check and that fact. We'll see how to get it there. But this is the true lateral of the neck of the femur. How to get guide wire right in the first try? This method that I'm going to discuss just now is specific for intramedullary implant. It does not work in doing a sliding hip screw or DHA screw. In that, this method does not work. But for all intramedullary nails for femur, this method will work, irrespective of the brand and the type. Whether you press 2 screws or 1 screw, this method will work. So what is it? The setup is like anything else. You have reduced the fracture and put him on the traction, draped it, and then you take on the first X-ray. For this is the position for you will take AP X-ray. But before that, what you have to do is to shift this in such a way that the machine is at 40 degrees to the long axis of the body. Patient is in this axis, you have to shift this machine that side so that it is at 40 degrees like this. The next diagram will make it easier. This is the long limb. This is the perineal post. And now this for AP picture, I have shifted it to 40 degrees in this way. So with the long axis of the limb, my beam makes a 40 degrees angle. So this is basic setup you should do before you start. Having done that, one proceeds with doing the standard draping and then inserting the implant. And when you come to this stage where you have got the things right and the and now you are about to pass, you may want to pass it touching the cortex, the this side, or you may want it right in the center. So you can adjust this length, and then you are ready to pass the guide wire. Then the new thing starts. So when you come to this, you take a lateral picture, and for that you tilt the machine by 15 to 20 degrees up to 25. One has to do a trial and error. Now, when what you see on this side, you remember you already inserted the implant, the jig is in position, and I have tilted this for lateral to 20 to 25 degrees, or maybe 15 to 25 degrees, and now you are watching at the screen. You will find something like this, or you may find something like this, or you may find something like this. Some one of the pictures will like this is the head and neck of the femur acetabulum, and this is the shadow of your jig. This is the shadow of your jig, which can be, I just given three examples, maybe like this, maybe like this, maybe like this. So what to make out of this is here. When you are watching this, you forget about the bone part. Don't look at the neck at all. Just concentrate on this side, on this angle, this view. Well, this is the shadow of the jig, and you have to concentrate only on this and forget everything else. We want to notice the shape of this jig, which is not exactly rectangular, 1, 2, but here it goes like this. So we don't want that. This is one. This is oblique, so that is what you remember. What you are seeing is the shadow of this tip, which is like here. From this surface is casting shadow, and it is something like this. So this means it is out of touch, it is lying posteriorly. That's why the front portion is casting shadow, which is like this. So you can now, you have to move the C arm. You have to move the C arm. You don't touch the jig. You have taken an approximate position where you would like to pass the K wire or the guide wire. Now you have to move the C arm to change the shape of the shadow. And next position you have taken is say something like this. Now what has happened? The other half is being seen and this is the different shadow. You have moved it too much anteriorly. You have to rotate it posteriorly or externally. So you have different shadow here. Again, you can see it is not rectangular, it is oblique like this. So we don't want. What we want is a shadow which will be move the C arm all the time till you get a shadow like this. Thing to notice is that this is perfect rectangle here. This edge is perfectly rectangular. You can see there the rectangle here. It's a perfect rectangular. This is most important thing. We move the C arm till such time that we get a perfect rectangle like this. Once we have achieved this, that's fine. Leave the C arm in that position. We do not touch it. Then we do the next step. How we have got this position is that tilting it to a certain angle, it may be 15, it may be 20, it may be 25. Whatever happens, we got to get this picture should be firmly embedded in our memory that this picture, that is what we want. Once we got it, is fine. Thereafter, we don't touch the C-arm. And then we move the jig. Hereafter, we move the jig. What has happened? Now we have established that the beam, X-ray beam, and this jig and the neck of the femur, they are all in one plane. So whatever we pass would be a true direction. It will not be an oblique picture, it will be a true direction. So most important is to get everything in one plane and then leave the C-arm wherever it is. You may lock it, you may leave it there, but don't disturb it. Now hereafter we move the jig. What we are, and the picture what you are seeing is something like this, perfect. But that we identify only with that rectangular shadow of the jig. This is something like this. You can see a rectangular shadow is constant. It should be always constant. As far as you don't touch the C-arm, it will remain constant. Now we move the jig. Suppose the jig is in this position and you pass the guide wire as shown in the dotted line. The guide wire will be further up, it will be anteriorly placed. So we don't want that. So now we move the jig, externally rotate the jig towards that way. See this rectangular stuff, that is most important. Move the jig now, externally rotated. Probably you have gone too far downwards. So if you pass guide wire along this, it will go posteriorly. We don't want that. But remember, the jig is looking exactly rectangular as you desired it, or as you achieved it by shifting the C-arm. Now you are not touching the C-arm, you are only rotating the jig either externally and internally till such time you move the jig all the time, till such time that you get something like this. Now, if you pass a guide wire, it will be in dead center. What you have to notice at this is that your shadow is still rectangular and your projected line is here. All you have to do is gently pass the guide wire and it will be 100% in the center in AP and lateral. This is one stage method and it's very effective. It has been described almost 11 years ago, but hasn't become popular. Once you adopt, it will be very, very useful in one stroke affair. Only thing you have to learn it by reading the original article. This is what you will get every time. With whatever type of jig you have a 4 jigs here, all the time you will get it. The principle is same. You have to have a square picture and then pass the guide wire in both places. It will work very well. This is the article which I will highly recommend for everybody to read. Nishi 2009. Very useful. And since these days intramedullary implants are very, very popular, adapting this method will save your time enormously and will also increase your confidence. So these two topics we can go for any questions if you have.
Very, very nice to understand this principle. Of course, we were trying up and down the zig, but first time I could get how to get it exactly rectangle. Very nice step, and I hope this would be very useful. Dr. Farke, any question from your side?
One question, sir.
Yeah.
Sir, once you have made the perfect rectangle and then you change the position of the jig, then again you have to change the position of the C-arm to get the perfect rectangle.
Now, once you have got the rectangular shadow of the jig, you leave the C-arm in position. I usually lock it up and then I rotate the jig to get it in the center. Sometimes you have to readjust the C-arm, but that is exception, not the. As a rule, you get the square rectangular shadow, lock it, and then move the jig. So inadvertently also your changes it and it works very well.
Oh, no. And no,
and it was also nice. Yeah, go ahead, sir.
One more thing is in the AP view, when you pass the guide wire, because it is flexible, many times the guide wire tends to go somewhere different from where the nail would or where the screw would end up, because it deflects from the calcar and it tends to curve up. So, is there any way that you can tackle this, or you have to just make adjustments on your own?
Well, only thing one could suggest is to go a little kephalite, no? Don't go very close to the calcar. And now these are a lot of people are using only one implant there,
Yeah.
TFNA. So there is no question of two implants going there. But if those who still want to do two implants, I'm not going to debate the one implant,
Yeah.
one nail or two nails. But if it is deflecting, one should stay a little away. See, after all, the hardness would be just not limited to very close. It goes across the neck. So you are as close as possible to the calcar. You should be all right. Even if it sinks, it will come to the hard portion anyway. But that is after you have done it.
Yes.
Yeah.
And it does happen, Farke sir, that guide wires deflect inside due to the trabecular condensation.
Yeah.
It does happen, or occasionally if there is a bone island inside, that also deflects.
Yeah.
So yes, but sir is told you. Sir, one question: in case
Also, it depends on the quality of guide wire. If you are using the same guide wire again
yes,
and again,
again.
then it becomes, it loses its stiffness. In the original, this came from the manufacturer. So recommended thing is to discard the guide wire. If some people find it rather expensive, then at least discard it after one or two cases. I'm sure in
Right.
2 cases, so guide wire will be recovered.
Yes. One question to you. You said don't abduct the other limb. So
Yes.
the opposite limb, but then the C-arm does not get adjusted if you don't do that.
I know, but when you are abducting it, you should know what's happening to the perineum.
Yes.
If for perforce, if you have to abduct it, is fine. But then many times we go right across and hold it like this and pull it out.
Right.
So that is bad. Once you are aware that abducting is going to cause some damage, you would be naturally restricted and abduct it only enough to accommodate the C-arm, or even allow C-arm to touch that other limb. Normally, you would just fling it out and say, "What the hell? I don't need that leg," but that causes damage to the perineum. So this is just to make aware that you are causing harm. Some adjustment requires, and once this is on back of everybody's mind, I'm sure they're going to be very gentle with the perineum.
There is a question from Mr. Dr. Abhinav. If you operate, you put the limb in internal rotation, and many a times the proximal fragment is in external rotation. He's talking about a subtrochanteric fracture or intertrochanteric fracture. So how do you position the foot? Do you again take it into external rotation, or do you lock it into internal rotation?
See, reduction of intertrochanteric fracture is a thing of my talk in the next half.
Okay, so we'll come to that. Yeah.
Exactly what you can be sure that you have achieved the right thing, whatever the position, whatever. So just wait for the next half to come.
Yes, sir. We'll definitely wait for that. Alok, welcome. We were just waiting for you. Sir has completed the first part of the presentation. So we'll continue with the next half, sir, now. Next part of the lecture.
Shall I start?
Just a minute, sir. We'll just check whether any question is there. Okay, sir, by that time, if you have any other question, you can go ahead.
Not really. This is a good idea. I'll try it the next time.
Yeah.
Right.
Another thing, Thakur sir, the question is, how does a scissoring make a difference onto the alignment of fracture? Scissoring of the two legs, 1 foot up and 1 foot down. That is what the question is.
The pelvis is square, is horizontal, isn't it? Pelvis
Yes.
is not tilted.
Pelvis is horizontal.
So if you have abducted or rotated the other leg, it is independent of this. The only thing would affect if the pelvis is tilted one way or the other, then there could be some issue. We all make sure that pelvis is level. Then there is no issue. The other leg you can independently do whatever you like.
Right. I think we can proceed with the next part of the talk, sir.
Okay. Fine, just side. Knowledge is of two kinds. We know the subject ourselves, or we know where we can find information upon it. I have always followed the second half of this quotation, and I have done reasonably well for it. And whatever I got it, I just put down in these 3 volumes. So anybody else who needs to look somewhere, he can go to one of these places and then find whatever is necessary, whatever is required. So our next section is pain relief in hip fractures. This I had done last time, but this particular, the video I showed wasn't very good, but the one which I'm now showing is really good. So whenever there is a patient with hip fracture, all that person wants is relief of pain. Any amount of diclofenac or a shot of fentanyl, everything is useless. But here is a method which is very surgeon friendly, very anesthetic friendly, and will relieve the pain for almost 12 to 14 hours. And the method can be repeated till the patient is taken for surgery. Even after surgery, the same block can be given and patient will have lesser demand for analgesics afterwards. So there is no sound here. For immediate pain relief, we need to block all the 3 nerves that cause the pain: the lateral cutaneous nerve, the femoral nerve, and the obturator nerve. It is possible to block them in one go because they are all contained in a fascia called fascia iliacus compartment. So all we have to do is fill the space with ropivocaine, and the way to do is this: point of entry is 1 centimeter caudal to the junction in this fashion. I'll show you the cross-sectional anatomy. First, there is skin and the deep fascia, and then after deep fascia, you have the iliacus fascia, and between that, this blue space, the entire all the 3 nerves are contained, and it is possible to reach this one. First pop is at the deep fascia, and the second one is at the iliacus fascia. These points will become clearer when the actual injection is being shown. This is building up the background for understanding the next video. Here is this is the preparation. You must have a skin marker. The lines have to be drawn every time you do it. Otherwise, things go wrong. Ropivocaine is the drug of choice. Don't use lignocaine. Anterior superior iliac spine and pubic tubercle. You have to mark that out. That's the pubic tubercle. Three sections. 1 centimeter below the outer third. Maybe a good idea to give a shot of lignocaine there so that patient don't get pain. That's the first pop. We have punctured the fascia. Now incline to 30 degrees and then go down and depict iliacus fascia. It is important to check, withdraw. Every time you push, you first withdraw and then push. So there are no vessels there, but still you should do as a good practice, withdraw and check, withdraw and check. Some fluid comes back, but which is fine. The block works for 12 to 14 hours. Anesthesia children, plaster application is also a good idea for me. This is the reference which you should read before doing it. This is really surgeon friendly. I always do it to my patients. Moment they arrive, I give it, or I get my anesthetist to do it. Residents should learn it and do it in casualty area only. That is the best way to treat patients. So this, once you have taken care of the pain, most orthopedic trauma surgery fracture is more likely related to failure because of poor reduction implant placement than the implant size and design. We always discuss whether intramedullary nail is good or the sliding hip screw is good. But what we need to discuss is really reduction and placement. How to get it in the center we just discussed. But let's see now what to do with the reduction. This is a usual patient that we come and we treat it accordingly. Reasonable reduction, one would say, and fixed it. This was on the second day of the surgery. Patient was in bed. After 1 month, this was the picture: collapse, shortening, and cutout. One is surprised, but then you check the reduction. There are two words: alignment and reduction, and they are not synonymous. When you do traction, the bones come into an alignment, but one is never sure whether the reduction is bone to bone. You are not sure whether bone to bone contact is available or not. So when we traction provides the alignment, and reduction bone to bone contact is most important. How to get that? We check this on the lower side. You can see there is a step. Though there was a reasonable alignment, there was not adequate reduction. There was no bone-to-bone contact on the anterior cortex. So the reduction was unstable. Naturally, the fragments moved towards stability and it's failed. The implants cut out. So this is the view: alignment and reduction, different things. How to make sure that one has bone-to-bone contact in unstable fractures and not just alignment of doubtful contact. The best location to obtain bone-on-bone stability is medially. Whatever the comminution or whatever the number of fragments, there is some bone left on the medial distal shaft, mainly anteriorly and to some extent on the medial side. Why there is bone always available on the anterior cortex of the neck? Because the anterior cortex fails in tension. As you would see in any other tension fracture, the fracture line always starts transverse. So the anterior cortex is remains strong because it has broken in tension like this. There is no combination. As against this, the posterior cortex is cancellous. It has failed in compression. As the anterior cortex breaks, the posterior cortex is bound to become crumpled. And it is already cancellous, so it crumbles and there is gap. So it's unable to offer any kind of support in reduction. Only the anterior cortex remains intact, and that is the one who will offer you the resistance. This is a typical picture in which you can rest assured that simple traction is not going to work. You're never going to get reduction the way you want or way you should have. This position is also called posterior sag. What is happening is that there is overriding and the anterior cortex overriding this, and the neck portion has sunk inside this joint. Now it is fixed, gone into this, and unless the shaft is pulled out, nothing is going to work. Posterior cortex is often comminuted because of the compression there, and is a posterior sag, as I said. So three things: anterior cortex overlap, posterior sag, and comminuted posterior this thing. Bone-to-bone contact does not occur. Posterior sag cannot be overcome by traction. One can use a pod to lift it up, but not for all fracture tables have it, not it works efficiently. The crutch being pushed from behind doesn't work. What is going to work? We are going to discuss in a minute. The methods exist, but they are not as efficient. And then we also don't know how to make sure that it is so. Longitudinal traction along the axis will achieve alignment of the fracture. You will apparently get a reduction, but there will not be a bone-to-bone contact because the neck is already locked inside there, as I showed there. Disimpaction of that malposition is absolutely necessary. And to do that, we need to pull out the shaft laterally. You got to disengage this locked system. You have to pull this one out. Then only this will become free. So you need a bone hook and give a lateral to disimpact. And then put a spike in the gap and then elevate it the fracture line so that you get the reduction. First step is to pull it out, then push a spike inside and price out the neck. An X-ray, the hook is being pulled out and this is to pull it out, price it out that way. In the AP picture, you will see something like this. Bone-to-bone contact is found in the anterior and medial context of the distal fragment on the shaft. Only this maneuver will achieve the stable reduction. So you have done this manual, pulled it out, put a spike, and then got the reduction. How to make sure that you have got it? Yeah, anterior cortex reduced and there is bone-to-bone contact. However, sometimes it remains tight and it is, you have got now anterior medial contact here and posterior combination defies reduction. Just don't bother about it. As soon as your anterior reduction is good, you are happy. This is a reduced fracture. Reduction is achieved when there is no palpable step on the anterior cortex of the neck. One could pass finger and feel it. If there is no step, then you have achieved your goal. If there is a step, redo the whole stuff. Pull it out with a hook and then lever it out so that you get flush anterior cortex. AP will show enough just as hairline track reduction. It's absolutely hairline track. That apart, but also feel with your finger that there is a plane surface there, then you have made it. In this you can see there is still a double, there is a double shadow here. Looks good, but you can see there is a double shadow here. Lateral view of the anterior cortex line is re-established. Sorry, that was the wrong interpretation of that picture. That was a good one. So when you see the lateral one, you have got a continuous line. At every stage of reduction in different patients, I'm showing that the line is continuous. Guide wire has been passed, a different patient, the line is continuous. Implant is going in, still the line is continuous. You have to check this line all the time when you are with the fracture because it tends to slip also. If it slips, take a correction action. But as long as this line is maintained, you are done. When this reduction is there, all the stability is available. Then these additional implants, they are debatable. The real strength of this fixation is here, not here. One may talk about these extra things, but if you get I would like to see a bad reduction and all these implants working. It doesn't happen. The reduction is very good, so everything will work. When a perfect reduction is achieved, use of secondary implants is debatable. Here we are. We see whole armor unit going inside. It's questionable. You achieved wonderful reduction. Your strength is there. One single standard DHS would have done. What all this stuff is doing is, I don't know. Show me a bad reduction and all this stuff and work doing very well. I will be happy. When it comes to intramedullary implant, that technique is somewhat different. Here it is, you pass the wire and you take the, here it is alignment and reduction is not very satisfying. In the lateral side, you can see it is standing out. So here again, you have to pass a spike and reduce that reduction. Or you use a hook also if required. Spike or hook. Usually spike is okay. It's difficult to pass hook there. And with the jig, you can always pull the shaft of the femur outside. So pass the spike as shown in this one. And the jig is here to pull it out. And then you get the reduction. There we are in the lateral. Again, you have the good reduction here. And you achieved it. So you go ahead and find it. Anterior reduction, then there is no issues at all. Two types of reduction. What is common in both is that the reduction is anterior side is good. Then it doesn't matter whether you have got all this or you just single screw. Doesn't matter whether intramedullary nail or not. The reduction, that is the key for intertrochanteric action. If you fail to get it, then nothing is going to work. You must reduce, disimpact it, lever it out, and then feel with your finger that there is no step anteriorly. Once that happens, then you pass your guide wire, pass your implant of your choice. It will work very well. And in the post-op period, patients are very comfortable. They have no discomfort. They are willing to walk. When there is unstable reduction, patients are most unwilling to walk. They complain one thing or other. But when the reduction is perfect, they are very happy and they will work. They will go. They will even volunteer to work there. Always achieve stable reduction of intertrochanteric fracture. Prevent implant failure by the same. Where reduction rates, the scale of osteoporosis become unnecessary. We always blame osteoporosis. Even worse of osteoporosis, the cortical strength remains. And you can get the anterior cortex reduction in worst of osteoporosis. So if you concentrate on getting the reduction, the stepless reduction of the anterior border, even in osteoporosis, your implant fixation will work. This is the article one should read over and over again and get the hang of it. Very important in his way. We have been doing these kind of reductions, but Dr. Carr has really defined it well so that it sets in your mind and you know exactly what to do next. I'm sure what I discussed is not new to you. Most of us have been doing like this. But there is no way of saying how to check it. Like in Marathi, they say you solve an arithmetic exam, so you double check it. This is the double checking method. Once you master this method, you will be a winner. Correct implant selection is also very important, particularly in SHS. There is reasonable confusion about selecting the barrel length. It is not matter of choice, whim, or availability. It is matter of calculation. We want that screw to slide in that barrel. And unless we have created a mechanical condition to that effect, sliding will not take place. So it is our duty to select the correct length of barrel. Barrel comes in two lengths, a standard length and a short length. So let's see what is what. The recommended sliding length is 25 millimeters. The threaded length is of the lag screw is 22 millimeters. So we calculate up. And the standard barrel length is 38 millimeters. So we calculate to 85 degrees. So when your lag screw length is 85 millimeters or more, you should use a standard barrel length. Then and then only you will provide the recommended sliding length of 25 millimeters. If it is 85 millimeter longer, use standard barrel. If it is 80 millimeter or shorter, use shorter one. 80 millimeter short, use the short barrel, which is 25 millimeters. 13 millimeter short, so it will provide that required 25 millimeter sliding. Here is a diagram. The screw is jutting out very much here. There's hardly 1/3 is engaged in this way. So when there is loading, this will bend. There will be tremendous bending load, and because of the bending, this will jam here. It will not slide adequately. However, if the barrel is well contained here, then whatever the load here, still there is enough place to enough mechanical situation for it to slide here. If you leave it like this, suppose it's 85 or 90 millimeter long thread and you use a short barrel, you will create this situation. And there will be tremendous bending load here. This will jam here, it will not go down. Either this will break or it will bend. And worst is sometimes it will disengage also. But once you create this situation, things will go very smoothly. So you have to be particular, 85 and longer, standard barrel, 80 and shorter, short barrel. There is no long barrel in the DHS set. It is standard barrel or short barrel. So use one of this. That's what I said. This is too long. This person was actually complaining that the thing has not slidden. It has not, it has jammed here. Of course, it's going to jam. For a long screw, you have used a short barrel. Had the barrel length will be somewhere here, it would have easily slid down. And the bending load was so high because of the short barrel. The barrel should have been somewhere here to support. That's why it went into bending. And this one, barrel length was very, very small and probably when they transferred the patient, somebody pulled the leg on the injured side and disengaged. This happened while transporting the patient from theater to ward. So one has to see all orthopedic implants are mechanically proven things and they write down what is to be done with them. If you read the original DHS manual, it will tell you exactly what I just said. Use of standard barrel, use of short barrel. We remember the name, but we forget the details. Like I said in the Cocker reduction, there is no traction. But moment you see anterior dislocation, everybody gets his hand up. Jor laga ke haiya. That causes all the trouble. So in orthopedics, there is importance to the detail. And these details will come only by studying the theory and remembering it. Many times in the group discussions, I hear, oh, forget the theory, let's do the practice. Your practice is based on your theory. You may deny that, but what you do is being guided by what you have read somewhere. It stays in your background. You may not remember word by word, but it guides you all the time when you make your decision. So what is required is getting your bearings right, knowing the details of an implant in the first place, and then start working on it. So that is the reason why failures occur, and this is one of the causes. Tip apex distance is again a very important factor, and one should strive to get it within 28 millimeters. Less than that, if it is more than that, it is difficult for your cancellous screw or the DHS screw. But these days we are using this spiral blade, and TAD is different than lag screw. It can move for this thing. Helical blade behaves differently to a screw, and a placement too close to the subchondral bone may lead to the penetration through the head. We want to be very superfine and go very close, 5 millimeter, 10 millimeter, then it may just perforate through that and cause trouble. So TAD for helical blade should be about 20 and not 10. So it should be a little longer. If you leave it more than 20, then it could cause a cutout also. But TAD more than can do a cephalic cutout. Lesser than 20 may go to centrally, but more than 30. So you should go between 20 and 25 somewhere. That will shine. But don't go too close. They behave differently than the lag screw. So that was that, and we could take some questions here because the next question is entirely different. this method, which I just described, is very good. One should really practice it every time you do a reduction. Make sure that the anterior cortex is aligned. There is no step, and that gives us a good confidence to go ahead and treat the patient. If there are no questions, I'll go ahead to the next part.
So what is the TAD for a two screw system in a long in a PFN? There's the older system.
Sorry?
What will be the ideal TAD for a two screw system in a PFN? The older system. I still use that.
Bob Garter has worked out only for one screw. But
Okay.
same principle, we can do that. When we use two screws, I suppose different things work there. It's not one single screw. They are already pressing it at two different points. So it does, but there's no laid down TAD as far as I know for two screws. Is there one, Ajit?
No, I don't know. I don't know because I couldn't find any reference.
No, I ask. Sometimes the questioner asks the question to bring out a topic. That's why I said you might know.
No. I don't know.
Okay. At the end, I have something very nice about asking questions. We will come to that today.
Yeah. There is a question from Dr. Ganjule. In
Yes.
comminuted trochanteric fracture, it becomes difficult to maintain zig and siam adjustments. So how to tackle in such situations?
In comminuted fracture, what?
It becomes difficult to maintain zig and siam positions.
See, this method is only for 4-point fractures. There is combination there, but whatever happens, you'll always find the anterior cortex or anterior medial cortex of the shaft is intact. And you got to align that to the position. Comminuted fracture is always difficult condition to handle. Nobody is doubting that. But there is with a little effort, you should be able to find a good bone on the distal fragment, which will be anterior or medial. And that's why I said, once you read that article in more detail, you will not have this difficulty. You will find something there.
Okay. Another question is, in comminuted intertrochanteric fracture, when the greater trochanter piece is separate, how do you take it into the intramedullary device?
Yes. If it is separate, then we have to reattach it. You have to get it back to the position. Just don't leave it lying here for various reasons, because if even the other fracture heals, is going to have a lot of lurch. So it's your duty to get it down and fix it with the whole thing. When it separates, I usually put a tension band wire around it and then pass it under the plate. I usually do plating. I don't do much of intramedullary nailing, but I do plating all the time. So for that, it should be brought down and then fixed. But one with a trochanter gone and intertrochanteric, it's a difficult situation. Then one may think that the bipolar would be an easier option. I would certainly be very careful going that way. I would still reconstruct the fracture in whatever way, and even if it goes into a little mild reduction, well, he could have a second operation. The complication rate in primary bipolar in many hands is not all that good. Of course, the moment I say that, there are at least 10 people who say, no, in our hand it's wonderful. I'm not disputing that. But it requires a lot more practice to get it right. You need to be more of a orthoplasty surgeon than a trauma surgeon to get it right.
Right.
Of course, everything is possible.
Another question is, what do you prefer the ideal position of DHS? Center or bit posterior?
Now, I prefer center. There is no need for bit posterior. If it is center with proper TAD, that's the best position there.
The surgeon has commented after that whenever I aim center, in the final check X-ray, I end up more superior in the neck.
Yeah.
Yeah.
That. Can I comment on that?
Yes, yes. Go ahead, sir.
That is a fallacy we get because of
Projection.
a Siam projection. On the X-ray, it looks slightly different. So while putting it center, my personal thing is to put slightly inferior and center, rather than posteriorly and inferiorly. Slightly inferior to the center line and then center. Then the final X-ray looks better.
Thakur sir, your opinion?
See that I just said the true epi and the Lowenstein epi. We work on Lowenstein epi. So there is some lag, there is some
Okay.
parallax there. That's why some position will be different. And again, when you are taking X-ray in the X-ray room and X-ray in the operation theater, the projections are different. So one may appear the screw may be slightly out, but as long as within that TAD distance, one should not be too upset about it. Slightly, if it's not cut out, then it's fine, not to worry.
And there are 4 or 5 questions on only one topic, that is, should a large lesser trochanter be fixed with DHS whenever you are operating with a DHS?
I don't fix it particularly. I'll just leave it alone and it works all right. But one wants to fix it, there is nothing against it. But whether you should fix it every time, I don't think so. I usually don't fix it.
Okay, sir, what is your opinion on that? A large fragment.
I almost never fix it. I fix it maybe in 1% of the cases, especially if it's a big posteromedial fragment extending along the shaft, along with the lesser trochanter in it. Then that is the only case when I put a screw anterior to the DHS pointing posteriorly into the lesser trochanter. But there's maybe 1% of cases, not more.
Yeah, but then we are really fixing the posterior fragment, which we never leave it out.
Yes.
It's that posterior fragment also has got lesser trochanter. Well, that's different issue. We have to take care of the posterior fragment. With that, the lesser trochanter is taken care of. Okay, but isolated.
No, isolated I never fix it.
Lesser trochanter, I don't bother.
Doesn't make any difference.
Another question is, how do you centralize the guide wire which has come out? How do you reposition it again?
See, again, I said, it is all in that theory book. You got to read
Yes.
that. DHS manual will tell you exactly how to do that. What you have to do is to take the short sleeve and put it in that hole. And in that short sleeve, the narrow end should go inside the drill hole. And on the broad side, you put the DHS screw in the wrong way. That means the threaded portion is looking towards you and the shaft goes inside that small sleeve. When you have done this, just pass the guide wire, it goes exactly in the same place.
Okay.
This is in DHS method.
DHS
And
math.
again, it is theory.
Yes.
Again, all your theory should be, all your practice should be based on theory.
And that is what many times nowadays we do not do. So
Dr. Chandak, you always, not you, but a large number of your friends say, what is there in theory? That is all in books. Let's
Yes.
do the practice.
yes.
Your practice is guided by your theory, unknowingly or knowingly. If you know the theory, you will not ask this question because you know where it is.
And
By
and
definition, the orthopedic surgeon is one who does the shortcut in the first surgery.
Exactly. So, my definition of orthopedic surgeon is that he will change a procedure the very first time he is doing
First time
it.
he's doing it.
Alok, I think you are struggling with the audio and video. Alok, it would be nice if you can join with your cell phone. Just a small tip. Any other question, Farke sir, you would like to ask? Or we go ahead?
No. This is perfect. No problem.
Yeah, that's perfect. So it was nice actually. So far it was good understanding the positioning, the two lateral X-ray and the X-ray we routinely obtain, the position and where the perineal post has to be done. Can we proceed, sir?
Implant position decides between failure and success, more so in a transcervical fracture.
Yes.
All this time, we are using 3 screws. It's a popular method, and we now perfected this, put it this way, wonderful. we get a reasonable amount of success sometimes, sometimes we don't get it. So it's half and half. How to improve on it? 20 to 42% failure is really bad. So that's why some people directly now go for a total replacement like this. What are the mechanical shortcomings of this thing? The compression is generated by the quality of the bone. If the bone is good quality, you can generate a very high degree of compression. But if the porotic, you will not be able to do it. It will just strip it off. So it depends on the strength of the cancellous bone and is obviously poor in the osteoporotic bone. The way we fix it is also unstable under varus fragments. The shearing force can be resisted only if the screw has a good hold at 2 points. Unfortunately, these screws have good hold only one of them have a good hold, one at the lateral cortex, one at the calcar. That's the only one, but other two do not have. So they are prone to varus failure like this. A force directed like this would definitely displace it out. Shearing force can be resisted only if the screw has a hold in 2 points. It doesn't have. Out of the introduced through the thin cortexes, they are all going here. This is a very thin cortex, doesn't give you a lot of this thing. Of course, it has one cortex. This one has it, but these two are only at one place. And this is only going through the cancellous bone. So one screw has this strong and this strong, yes. This is weak and it's all cancellous. So only one screw out of three is having good hold there. If we are able to pass something vertically, then it will be a good support. It will just support it like that. It will work against the varus loading also. Like this. So one should try to do it like this. Hat on hook. This is wonderfully stable thing. You can just think this is a hat on this hook. If you can get something like this, that will be really useful. So this is a new method which has come up, biplane double supported screw fixation, BDSF for strout. A transfer flexion and three screws, two are parallel, one goes vertical like this. We'll see how it works. Another patient, same way, AP and lateral. AP and lateral. What are the principles of this biplane double support? The guide wire is to be passed in a particular sequence, and the screws are also had to be passed in a particular sequence. Let's see that. At least two screws should have two strong cortical support points that are spread out in the neck. At least one screw should be as vertical as feasible. So two screws should have strong cortical support and one should be as vertical as possible. So we pass first guard from posterior third of the lateral cortex, the posterior third of the lateral cortex, and it is going anteriorly in the lateral view. So posterior third of the lateral cortex is the anterior third. That is the first one. It's also going close to the calcar. There it is. Then it gets support at the lateral cortex. It gets at the calcar here, and it's going posterior, anterior. Sorry, posterior. The lateral, it is going anteriorly here on this side. The second one is parallel, about 2 centimeters above, and is going. So these two will produce maximum compression. This has got good support. This doesn't have, but it is helping you in getting the compression here. After this, the traction is released and the whole thing is impacted. So the thing settles and then it is tightened up again. So now this is the anterior portion. You have two screws lying anteriorly, one below, one here, and in the lateral section. Now we are having done that reattended, we pass the third screw or the third guide wire. Guide wires are passed first. I'm just mixed it up just to avoid repetition. So the third screw is the most interesting one, and we should talk about it. It is inserted into the medial line on the lateral cortex. Lateral cortex, medial line, and it is directed towards the posterior third. The first two are in the anterior third of the head. This is in the posterior third from the lateral side, and it is about 2 to 4 centimeters away from the last screw. If it is too close, there is a danger of shaft fracture. 2 to 4 centimeters, this danger doesn't then exist. And it is directed towards it. In the center, there is no wire at all. Now, just a minute. I think there is
There are some loss.
now there is a video. I'll show you that later. Don't worry. So what is happening is this is the third screw. How it is going? It is through the lateral cortex. It is supported on the calcar as well, and at the neck here also. One support, two support, and it is supporting there. So it's one support, two support, and there. You can see here, this is the base lateral cortex. This is the neck here. Again, cortical support here. And now head is supported here. So it's double support to this screw. Number 3 screw is the magical. In a different plane at an obtuse angle, it is going. It's not a lag screw. It does not compress the fracture, but it only functions like a support beam. And this procedure has also given a new function to a bone screw of a support, like a beam-like support, a supporting, which I discussed in the common bone screw. This is the one. It does not, I'm repeating, it does not compress, it just supports it like this hand on the hook situation, one of the most stable situations. Supported at 3 points, it is the lateral cortex, inferior cortex, and posterior cortex, lateral, inferior, and posterior cortex. Use strong support at the posterior inferior segment of the head, which is often comminuted. Posterior inferior segment, usually there is comminution here. It is supporting just like that back. It is not compressing. Compression may not be useful, but support will be. So it is just doing that. So 3 point lateral cortex, inferior cortex, and posterior cortex. Lateral here in AP and the posterior cortex here. Please. These 3 points well supported, all cortical support. And we have widespread between the middle and distal, there is a widespread, so there is no chance of fracture happening here. It's a strong situation there. Because of the distance, it's a very long screw. When you use a very long screw, the pressures on these are low, the stresses are reduced. So that's an additional advantage. I repeat, this is only working like a support, not the compression screw, as you can see. These two are compressing. This is only supporting that. And it has got hold here, and at the posterior cortex in the third dimension. Stronger resistance to virus collapse, easier sliding, prevents cutout, and maintains strong fixation. So this is a new method. It's worth thinking about it. First and third, so I eliminated the number 2 screw by digital manipulation. It's called Photoshop. So for clarity, these two here just common here, one at the posterior side, one at the anterior side. There are no screw in the middle zone. Nothing in the middle zone in both the patients. Middle and lower screws support each other's role as axial beam, supporting at different inclinations. Arrangement offers strong support against walking loads which are constantly changing. Because the third screw is going almost vertically, and the first screw or the lower screw, the middle screw we passed the first time. So that too, they are working at 2 different angles and they are supporting different directions. So they are withstanding all the loads in different directions. While when you sit and get up, the line of load changes dramatically from 90 to 180 degrees. So there's a lot of biomechanics. I find very great similarity between this stand and these two. This thing. Like these 2 points are supporting the whole thing. The head is supported by the third and the first screw like this. The middle screw is here in between, but that doesn't take part. These two, they are working very well, just like these two. Example, is support here, and these are all supported like this. Very, very like the third screw, it is working like this. So in double support that we often use, the both screws are in the middle. They are not, they are all in the cancel zone. There is no, this is a very weak area. Doesn't work very well. Here there is one support, but nothing on this one. They're not spread out. They're all parallel in the center one. Larger diameter does not convert to a superior compression porotic bone. And there is no beam-like support to achieve a hat-on-hook stability. The hat-on-hook stability is the ultimate in fixation of fracture neck. And that we should try and get it here. These are all these X-rays I showed. They are straight from Paolo only. He was kind enough to send me some samples, examples, and I'm sharing them with you. His article has been recently republished in American Academy of Journal recently, but his original article was in European Journal, and that one should read this one or also the one published in American Academy. And in fact, the American Academy one has some modifications, and one should read that as well. Once you read, it's not so difficult to pass those screws the way he has described. Only thing, one has to follow the technique and the sequence that he has guideline. Once we do that, I think we'll treat our transcervical fractures in a superior way than what we have been doing with the 3 cancerous screws obliquely. We have questions.
I think the topic is so interesting that there would be a lot of questions. So the question which is there, do we do away with 3 parallel cannulated cancellous screws? Or the technique still would work?
I just discussed there that the 3 cannulated screws work the way I've shown all the fallacies of those 3 screws.
Yeah.
They don't generate too much. They are on the lateral side, they are in a weak area, there are no additional support, etc., etc. And they do not prevent the varus load. If we change the position, like Filippo has advocated, it stands to mechanical arguments that it would be a stable one. So it is a new method and follow that.
Yeah.
He recommends only cannulated screws to be used on this technique. You can't use solid screws because they will go haywire. It has to be.
On that note, would you promote the newer systems from Stryker, etc., where there is a lateral plate to the cannulated screws?
Lateral plate. Yeah, lateral plate is. There are some arguments about it also. I'm not very much in those. I'm just concerned with this or that. So I don't think I have a very valid opinion on that.
Okay. Okay, sir, any opinion on that? What would you consider the best construct for intracapsular fracture? 3 screws, 3 parallel screw, or 1 cancellous screw across the fracture side? What would be your opinion and experience?
I was using 3 parallel screws, then I shifted to 4 parallel screws. Now, for the last 2 years, I've been using a DHS and a parallel screw along with that. But not exactly parallel, it's slightly off the parallel. And it has been working. But this Dr. Thakur's concept is very good. It's something new. I'll have to try it, but I'll have to get screws which are 120 and 130 mm long first.
Yes, we'll have to
my box has only up to 110.
Yeah.
So first when I get those screws,
Hello, do we have questions?
Yes, sir, we do have. I'm just getting
Dr.
back.
Kharge, maybe not. Our patients are not very tall. So you may not 120. These are Romanian patients. They are very tall people. You may not need that, but it's good to have a longer screw in your armament.
Yeah,
just
then
go
you get close.
60 and 70.
So in his description, sir, whether the screws would be crossing the fracture side, the threads, or they would be beyond the fracture side?
The threaded portion has to be beyond the fracture side.
Beyond the
But for
fracture
the
side.
last screw, it won't matter, I think, because it is just a support screw. For the
Yeah, but
vertical
still,
screw, even if it is slightly longer, it won't make
they are all short threaded, 16 millimeter threading. So every time you pass them, they have to be beyond the fracture. Okay.
Yeah. Alok, you are. It seems you are struggling like a centrally placed guide wire. So go ahead
am I
with your
audible?
question. Yeah, you are audible. Go ahead with your questions.
So the question is, this is from Dr. Atul Srivastava, is the IOA secretary now.
Okay.
BDSF, do we need to use a washer in the beam screw as shown by you, as it is not a compression screw?
It's safer to use washer.
Okay.
It is safer to use washer. And as I said, whatever X-rays I showed are from Filippo himself. They are not my X-rays, the Filippo's X-rays. And if he has used the washer, I would stick to washer in all the.
Okay. So the
but it's good to use washer because it dissipates the forces of the shaft. If I tighten it a little more, then I may create a weak spot on the lateral cortex. I don't want that. So washer will dissipate my compression force and would be good. It's good to use washer.
So Alok, the mantra from Thakur sir is read the technique and follow the technique exactly so that
Yes.
we get a desired result. Yes, go ahead with your next question.
The next question. So, what will be the length of this screw?
What would be the length of the screws? The average length of the screws, you mean to say?
Yes, sir. This the third one which is passing in the posterior cortex.
The Filippo screw, yeah.
Yes.
Yeah. In Philippo's case, it is 120 to 130. So I just said the patients are tall. If patients are 5'4", then it will be just 100 or even 90. So one has to be on the table, decide what requires. What is essential that you have to give distance between the second screw and third screw. That's why you need a long one. It's safe to have as long as 130, but you may not need it in India.
Okay.
You may get away with 100, 110.
20. Right. Alok, other questions you can take up?
Yes, sir. So this at present no more new questions are there.
Okay, okay.
I'll let you know, sir.
Yeah, as soon as they are there, you can just let me know. Yeah.
If there is no questions, I have something else to tell you also.
Yes, sir. We go ahead with the topic. We go ahead with the lecture.
I go ahead? Okay.
Yeah. Yes, go ahead.
See, Dr. Ashok and Dr. Chandak have agreed that we should do something else than orthopedics. And what we're going to discuss is how not to make a presentation. This will be topic next week. It will be more entertaining than educative, but it should be all right. So 12th May, same time we will do that. Before I end, there is something little nice. Whenever we go to a conference, we need to ask questions. And sometimes one wonders what's going on, why there are so many questions. Not a webinar like this here, it doesn't matter, but here in a hall, people ask questions. And they say, well, should you ask a question or not? Well, I got a little small algorithm which is in a lightweight. Do you actually have a question? Well, somebody is going to say, I just, that are you trying to show off? The answer may be, yes, I do. Okay, then beat it, go ahead, get it done. Some of you are serious and no, I don't want to show off. I actually have a question. All right, then are you sure it's not a dumb question or the speaker has already answered it? I don't think so. A serious one will say, but the one who wants to show off is going to say, maybe, but I still want to ask a question. All right, do you want to show off again? Yes? All right, proceed with caution. But the sincere one will say, no, I'm not trying to show off, and I don't think it has been asked. Then what it is? Do you really need to ask that question in public, or could you follow up with him later? Well, if it doesn't matter, then let me ask you, are you the person who has organized the seminar and is asking the question because no one else is, and awkward silence is making everybody uncomfortable? Something like what we saw today? Well, if it is so, thank God. Just ask the question so we can all get out of here this way.
Yeah.
All right, if you are not the organizer and you still have the question, then okay, you have a legitimate question. Do you actually care about the answer? The smart one is saying, no, not really. I'm just trying to make sure. And the sincere one would say, no, I actually have the question. I have a legitimate question. Okay, then go and ask your question. When we go into bigger conferences, while they in the between the sessions they put up the slide, this question time, something like this. Many times I think they should also put up a small postscript or small note there. And that should clearly assure all the question answer wallahs that food will be served to you even if you do not ask a single question. Ladies and gentlemen, I'm not trying to downgrade people who ask questions, but just in light to note, many times one finds that either people are trying to show off or doing things. So do just a funny look at the question answer sessions. So that should be all for today. And what I just read, this knowledge is of two kinds: that which is absorbed and that which is heard. And that which is heard does not profit if it is not absorbed. So we have been hearing, and I'm sure everybody is going to absorb so that everybody becomes an excellent surgeon. Excellence is never an accident. It is always the result of high intention, sincere effort, and intelligent execution. It represents the wise choice of many alternatives. Choice, not chance, determines your destiny. That's what Aristotle said. So we all need choices, and those who make hard choices always go to the top. Those who make soft choices, they stay in the pool. So it's up to us to make choices, but the choice will determine what is our destiny. Thank you for your attention. Next Tuesday we'll meet, but in a lighter mood. So I don't have tension and work for the next 3-4 days. I'll be okay there.
Yeah.
And
Thank you, sir.
this would be how not to make presentation. That would be the theme, and I hope that you will enjoy that one also. And definitely that will be the last one.
Yeah. Sir, in spite of this
Yes,
last few slides, Alok has definite question. So Alok, go ahead. Yeah, just a minute, Alok.
Alok, you are muted.
Alok, go ahead. Ask your question.
So what not to be asked, I have really come across it, but there are a few good important questions. One of the surgeons from Mumbai, he's asking, Dr. Mukhi does not remove the top nut and always uses a long barrel. What is your opinion on this?
Sorry, he doesn't use, he always uses a long barrel.
Yes, he always uses a long barrel and he does not remove the top nut.
You mean to say the compression nut?
Yeah, yes, sir. Yes, sir.
Compression bone.
It doesn't remove the compression nut. Say once you have applied the compression nut, you have applied the compression, there is no function of that compression nut. I always remove it for one reason, that it sometimes becomes loose and falls off. And then patients get very excited and I want it out. It's unnecessary. So once the compression is achieved, I take it out and that's the end of it. Only rarely it should be retained. If you are stuck with poor implant choice, a very short sling, and you are not sure whether the nail is telescoping inside the sleeve enough, then you can leave that compression nut in position just as a locker. But otherwise, there is no function. Why Dr. Mukhi leaves, he will only answer. But technically, or as far as the manufacturer's guide is concerned, that compression nut has no further work, and they recommend it should be removed.
Okay.
And as far as choice of standard barrel, mechanically speaking, it is not right. You should have a choice of short and long, and I explained why it should be done. There is a logical, mechanical answer to this.
Yes.
One should follow it. All that.
So
Yes,
another,
Alok. Yeah, go ahead, Alok.
so
No
another
problem.
question is, how do you drill the lateral wall for the DHS? In an oscillating mode, the lateral wall doesn't blow out.
This question, I suppose, must be from Dr. Mukhi.
Yes, sir. I mean, Dr. Kushmukhi.
Yes.
Okay. How do you deal with the?
So how do you drill the lateral wall for the DHS? And in an oscillating mode, the lateral wall doesn't blow out.
While making the hole,
Yeah.
he used the oscillating mole of the drill.
Yes,
So
sir.
that is a recommended method. But if I'm very worried about the lateral wall, I start with a smaller drill bit. First, maybe 2.5, 3.5, 4.5 like this, and then go for the larger one. But it's a tricky situation, and there is no firm answer for this. You can gradually increase it. But if you have the facility of the oscillating drill bit, that is very good. That is recommended. But not all hospitals have it. So other alternative is to go step by step, start with 2.5, 3.5, 4.5, etc., etc.
So another question is there.
Yeah, go ahead, Alok.
So this is from Dr. Damodaran S. from South India. In helical blade, if not buried in subchondral bone, won't it cut out? Will there be a good purchase below 20 mm?
See, that is a paper. They have come out with this, and they have also made recommendation to the manufacturers that there should be change in that. The manufacturers have agreed to whatever the paper has been found out. Whether they have put it in practice or not is a different issue.
It's 4 o'clock.
They have shown by their experimentation in that particular paper that it is safer to leave it out because the mechanism is different. If you look at the spiral blade and a cancerous screw or a lag screw, you will immediately find out one has a sharp edge, one has a blunt edge. So the sharp edge is likely to cut through outside. Common sense. And if you leave a little thing out, it is safer that way. If the personal experience is different, I can't help it. You can write another paper. But I'm just quoting that paper which wants, and they, in their preamble, they have said that we had told the manufacturers and they have accepted our argument.
I think
Yes, sir.
all the questions are answered
Yeah, exhausted.
satisfactorily. And they were interesting questions. There were certain experiences also shared. So that was good. Parke sir, you would like to comment something?
No, it was very interesting.
Yeah,
I
it was
learned
really.
two things new today. So it's very important. At
Yes.
my age, learning new things is really necessary. We tend to become complacent. Because I was happy with the DHS and parallel screw, but now I'll try the different method
Yes, yes, yeah.
of fixing intercapsular fractures, and let's see how it works out.
So thank you, sir. Thank you very much. It was really enlightening. And then we'll read certain basic techniques and follow the DHS techniques. And it does help us. Like in all your previous lectures, we tried to follow up the principles, and many people are adopting the real principles. And it does open up our mind to read all those things. So thank you very much for bringing that out. And we definitely sure be meeting next Tuesday, same time at 2:30. Anything else you would like to convey? Just please convey.
I don't think bad.
Yeah.
Okay, fine.
Okay, sir. Thank you.
Thank
Thank
you.
you very much for that. And we must thank Ashok Sham and Dr. Neeraj for bringing us this platform. All of us are well connected during this COVID time, and we are really learning good techniques from our masters. Thank you, Alok, for helping us out with those questions.
Today I
And
had a lot of struggle with my.
yeah, no problem. And you'll have to just correct whatever problems you are facing.
Thank you, sir.
I think. Thank you, Ashok. Thank you. That was wonderful. And sir has agreed for next Tuesday for how not to present PowerPoint presentation, and that would be very useful for all of us. Thank you very much.
Okay.
Thanks.
See you next week.
Thank you. See you next week. Thank you, Farke sir, for joining.
Thank
very
you.
much.
Thank you.